Okay, my clock just struck 12, so let's get started. All right, hello everybody. My name is Meg Bruner and I'm with the Northwest ATTC. I'm sitting in today as your host while Bia Carlini is out of the office, and I'm very excited to get to be a part of today's presentation from Michelle Marikos. Just a few notes before we begin. If you have any questions during the webinar, please feel free to type them into the chat box at any time, and then we'll have a short Q&A after the presentation. The slides and a recording of this webinar will be available later today on our website, and you'll get an email from me this afternoon with a link to those and also a link to a survey about the webinar today. Just as a side note, we've been offering a $5 gift card for completing our webinar surveys this past year, but due to changes in the survey process from our funder, we'll no longer be able to offer that starting next month. So this is the last webinar that you can earn $10 for by completing both the surveys that we'll send out. Definitely take advantage of that 10 bucks, it's great. We did recently start offering certificates. Hold on, I'm trying to change the slide here. There we go. Certificates of attendance, though, which you may be able to use to get CEU. These will be automatically sent out next week to everyone who sticks around for the whole webinar today. You don't have to do anything in order to get a certificate unless you're watching this webinar in a group. If you're in a group, please have the person who actually logged into Zoom email us this afternoon with the names and email addresses of everybody in that group who wants a certificate. Otherwise, we won't know that you attended. And we need that information within the next 24 hours, so I'd suggest just sending that email to us as soon as the webinar is over. Our email is right there on the screen, northwest@attcnetwork.org. Okay, so let's get started. Today's webinar about peers for chronic pain is being presented by Michelle Marikos. Michelle is a certified peer support specialist who has lived with chronic pain herself since 2003. She became an Oregon Pain Guidance Steering Committee member in the fall of 2012, worked on the Southern Oregon Pain Conference planning team from 2014 to 2017, and became a certified peer support specialist in 2013. She has also worked as a Living Well educator and was a participant in a media campaign from Oregon Pain Guidance that won an Emmy Award. Very cool. Michelle attended the Mayo Clinic's Pain Rehabilitation Clinic in 2012, and through that program was able to taper off high-dose opioids and benzodiazepines. Today she'll be sharing her lived experience with us and talking about what peers can do for the pain and opioid crisis. Michelle, thank you so much for being here today, and I'm going to transfer control of the screen over to you. And then you can get started.
Thank you so much for having me.
Okay.
So here we go. Let's try this out. I believe, there we go. There are my slides. Very good. So what peers do, the lived experience in giving back to peer support specialists for chronic pain, educating, support, and hope. So our learning objectives today are really understanding what it is like to be a patient living with pain, communication gap and bridging it, why peers, understanding what pain patients do not know and what they are never told, understanding and screening for the transition from acute to chronic pain, and then I'm going to give a little bit of information about a toolbox and some resources. So let's get started. So the journey to hell and back. So my journey started in 2003. I was attending school at a college in Chico, California. I was part of a sorority. We were at a sorority function at our sorority house. And so we were on the second story balcony of that sorority house, and I was pushed off that balcony. I flew through the air. I grabbed onto another kid thinking we're not going to go off the balcony, but he came with us. And so I landed on my head and he landed on me. And so that started the journey of, kind of this acute injury. Went to the hospital and was diagnosed with whiplash. Their x-ray equipment at that hospital was not working at the time. So they released me and said, hey, we'll put you in a soft collar. We'll give you this medication. It was opioids at the time. And, follow up with your doctor. And of course, I'm a college student. I don't have a doctor. So about a week later, it was, really intense. I was very, very ill and, had concussion symptoms, had, very terrible symptoms at the time. And so I ended up going to a doctor of osteopathic medicine, and he said, hey, let's get you an MRI. We'll see what happens here, and we'll see what happens on the MRI. So the MRI was at 7 a.m. that morning. He calls me at 8:15 and says, do not move. You cannot be riding in a car. You cannot be washing your hair. You cannot be doing anything. You need to stay as still as possible. We're going to get you back into the hospital. We're going to put you into a brace. You have crushed vertebrae, and kind of, your neck structure is very unstable at this point. So I finally get stabilized back at the doctor, and he says, okay, you have, these crushed vertebrae, bulging discs, there's a good chance that, you may be paralyzed. So don't, really move. So we get into the neurologist. I get, into a stabilizing brace. My mom comes down from Oregon and comes to pick me up, and they say, okay, well, we can't helicopter her back because that's going to be too much of a jolting ride. You need to put her in the car, surround her by pillows, and drive as fast but as safe as you can to the neurologist in Southern Oregon. So we did that. The neurologist here in Southern Oregon said, okay, let's see what you have. So he looks at the MRI, and he's like, okay, well, I think I'll put you in this brace and we'll just kind of continue on. So he looks at all the kind of information, and he releases me. And as soon as we get to the parking lot, the nurse comes running back out, and she says, oh, no, wait. He saw actually what's really going on. Come back into the office. We're going to put you into a halo. So I was put into a halo and continued to heal inside of a halo brace for about 6 months. So I tell you the part of the acute part of the story is that, that was a hard journey, really not knowing, as a 23-year-old, college student, I really didn't know anything about the medical system, how injuries worked. I didn't have an advocate saying, okay, these are the steps that we're going to do. It was, the situation was, a dire situation, but nobody could really navigate you through the situation of like, here's step 1, here's step 2, here's step 3. And so that was really difficult. And that whole time I had been opioid naive, but I'm now on very high doses of opioids, very high doses of muscle relaxers, of course, for an actual acute injury. And you should be on those very high doses for that acute injury. But the problem was that medication never got tapered. So as time goes on, 6 months into the injury, it's like, okay, well, let's take this brace off. And so we take the brace off, the pain never changes. The opioids never change. The medication never changes. And so I'm kind of left in the situation of now what? And, of course, being a young person, you have all these, dreams and aspirations and all the things that you're supposed to be doing. And I had really stopped doing everything. I had just been injured. So I kind of picked up my life and said, okay, I'm going to go back to school. I'm going to get my college degree. I did that. I graduated with a bachelor's of science in agriculture business, which had been what I was going to school for. And I I was lucky enough to have some property with my family, and I was lucky enough to be able to plant an orchard and not have to work for somebody else on somebody else's hours, because I really knew that I couldn't be working for someone else, because I really was in this very awkward stage of not being able to work full time, and I couldn't really manage my pain, and in this difficult situation. So a year goes by, I'm still doing physical therapy, I'm still doing the medication. And then another year goes by, and I'm still doing these, very intensive things. I'm doing really anything that the doctors can say to do about, okay, well, let's try this next therapy. Let's try this facet joint injections. Let's try nerve blocks. Let's try all of the things that we can think of to help you with your pain. And I was up for all of it. I did really any kind of therapy you could do. I was on board with it. Yes, please. I want to do all of it. So in the meantime, still taking medication, still, going to doctors weekly. And so then in 2011, I woke up one morning, and so I hadn't had surgery up until this point. But in 2011, I woke up and went downstairs to get my coffee like normal. And I rubbed my eyes, and I heard a pop. And it was one of my discs actually collapsing. So it was this new pain that I had never felt before. And so that kind of sent the medical, system into a different realm of, okay, now it is time to get surgery, and it is time to have some kind of other intervention. So my thought process was like, yes, I want to do surgery now. I'm ready for surgery. This is going to be the thing that actually helps me with my pain, and I can continue on with my life like I'm supposed to. So I had the surgery, and it was a fusion, and unfortunately it did not work. It was a failed cervical fusion. So that was, this kind of moment of, well, that surgery didn't work. Let's go on to the next one. I want another surgery. I want any kind of intervention that's going to help me with my pain. So I'm still on very high dose opioids. At this point, I'm on extremely high dose opioids and really bedridden. I had stopped kind of doing anything about my life. I was in bed, not participating in life, not doing any social activities. I was not planning on really having a future. I didn't know what my future was going to look like, but it was very dark. So depression had set in, anxiety about my pain had set in. I was really circling the drain at this point. And so that was, this moment of like, okay, yeah, I want another surgery. So they'd said, okay, we can do another surgery, but it's going to be a full cervical fusion. And, I didn't really know at the time what that meant, but I, kind of gotten some information about, okay, they're going to fuse all of my cervical vertebrae, and I'm going to lose 70 to 80% of the movement in my neck. Am I prepared to do that to get out of this pain? Yes, I was very prepared to do that, which is really a big kind of shocking, glaring moment in my eyes of I was ready to do anything because I just really wasn't functioning and wasn't participating in life whatsoever. So I go back to the doctor. Yes, let's get an examination for another surgery. And so the surgeon looks at all of the information, and he is like, yes, we will do the surgery, but you cannot do this surgery with the amount of opioids that you're on. And it was like, well, what do you mean? I did the surgery, a year and a half ago with the amount of opioids that I'm on. He's like, yes, but you're on even more now because of that last surgery. So we have to taper you. And it was, kind of this, I don't know how to do that. How are we going to do that? Just panic ensued. I just could not even hear the words that he was saying. So he said, oh, no, don't worry about it. Go back to your doctor. He'll know exactly how to taper you. Okay, I'll go back to my doctor. So we spent a 5-hour car ride getting home from that appointment, and I cried the whole time. I just was hysterical. I couldn't even think of how am I going to live without opioids? I can't, at the time it was, painkillers, my pain meds. I can't live without my pain meds. I didn't have anything except for this medication. This medication was everything to me. So get back into my primary care doctor, tell him, okay, the surgeon will do the surgery and we will do that, but I can't be on the pain medication. He wants to taper me. And I loved my doctor so much. My doctor was such a wonderful man. He really, helped me in so many situations, but he looks at me that day and he's like, well, did they tell you how to taper? And it was that proverbial, oh shit moment for both of us, that he knew he didn't know how to taper me, and I knew he knew not how to taper me. So that was really such a difficult moment because I trusted him so much and saw the, kind of pain in his eyes too of he couldn't help me in this situation. So that kind of got me to another place of like, all right, well, I want to go to Johns Hopkins, or I want to go to Mayo, or I want to go to Cleveland Clinic, or I want to go to, a centers of excellence place that can, deal with me because I just feel so lost. I don't know what else to do. I need like a large medical system to take all of the things that I'm going through away. So he said, okay, well, we'll get you to where we can get you to. So Mayo actually was the first appointment in Rochester. And so we fly out to Rochester, and the surgeon there says, yes, we can do the surgery. But again, you cannot be on the amount of opioids that you're on. And so again, panic ensues. And they say, no, 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 wait a second, don't panic. We have a program. We're going to get you into this program. It's called the Pain Rehabilitation Clinic. You're going to go to that program. You're going to learn about pain. You're going to learn about tapering. You're going to learn about medication. You're going to learn all the things that have been missing. And I kind of was like, oh, I don't know. I don't know if this is going to be the program for me. I don't know if this is going to be a bunch of old men sitting around complaining. I just really didn't have an idea of what this program was going to be. So I went into the interview, sat through the interview. They said, yes, we have an opening in July. This was in April. And so, okay, I will come back in July. And I was just scared to death. I just shook the whole time. I just couldn't stop shaking. So I get there in July, and it was, okay, I'm here. I'm doing it. And the program starts, and it's an 8 to 5 program, and it's a total of 6 weeks. You do your taper for 3 weeks. And that was the thing that got me moved through my chronic pain. I actually learned everything I had never learned about chronic pain. I had learned about pain catastrophizing. I learned about central sensitization. I had learned about medication, what the medication could and couldn't do for pain. I had learned about all of my personality type, my traumas, all of the things that I had gone through previously that really kind of set me up for you could live with chronic pain in the future. So 2 weeks into that program, I had been going through my taper. I had, had some difficult moments, but not too bad. I was okay so far. And so I walked into class, and one of my good friends had kind of made a joke, and I quipped back, and I had this aha moment of, wait, where have I been this whole time? How come I couldn't make jokes? How come I couldn't say funny things? Where have I been? In that moment of realizing I had been numbed for a decade of my life, and I just couldn't even figure out where I had been and when I had lost myself. So that was that moment of like, okay, I'm going to continue on with this journey. I'm going to continue on with tapering. I'm going to do this. And the taper, it was brutal. I mean, it was hard, difficult, sick as a dog, all the things that you say, is to patients, that's all true. But it was the most motivating, best thing I've ever done, because it got me through to where I needed to be. So, that light at the end of the tunnel, the Mayo program was that light, and it gave me, all of the skills that I needed to be able to live with chronic pain and really successfully live as a person in general, but to be able to live with chronic pain and actually help others to do so also. So how did I become a peer support specialist? So when I came back from that program, I came back in August, and I had a very good friend that worked at our county health department. And so she said, hey, our county health medical director is having a lunchtime talk. And do you want to come to this lunchtime talk? It's all about living with chronic pain and what providers should, do to help their patients. I was like, oh, I don't know. And again, this kind of moment of questioning what other people are doing. So went to the lunchtime talk. The talk was done by Dr. Jim Shames at the Jackson County Health Department here in Southern Oregon. And he was showing all of the films and all of the slides that I just watched at the Mayo Clinic. And I, sat there just kind of like, yes, he finally gets what is happening with people living with chronic pain. He gets it. He fully gets it. And so at the end of his discussion, he had, a Q&A, and he'd asked the audience something. And I must have kind of quipped up and said something smart. And he cocked his head, and he's like, well, do you have a story to tell? I said, I guess, maybe. Maybe I do. Maybe I don't. Maybe it's something good. And so he invited me to their group. It was a at that time, the opioid prescribers group here in Southern Oregon, what became Oregon Pain Guidance Group. And so instead of doing a 20-minute presentation, they questioned me for 2 hours about what it's like to be a patient living with chronic pain, and what is it like to taper, and what is it like to not use opioids, and how do you live your life, and really all the questions that providers want to ask their patients but never get a chance to ask their patients. So that was really, it was a wonderful, wonderful kind of introduction into that group. And so at the end of that meeting, they had asked, do you want to be on our steering committee? We would love to have a patient voice on our steering committee. And I was like, yeah, okay, I could do that. That sounds good. I really don't know anything about, medical systems in general or sitting around with medical providers, but yeah, sure, I would love to. So, and in that kind of that moment of this missing voice of peers talking to other peers, but peers talking to providers also, that providers needed to be able to hear from patients what they were really going through. So that's again another aha moment of, okay, I'm going to go and get trained as a peer support specialist. And so I was dual trained in addiction recovery and in mental health, because really chronic pain lives in both those worlds very much so. So, and then kind of living in this world of, where does a peer for chronic pain live? Where do you actually go to work every day? So I had started in a comprehensive pain rehabilitation clinic that our county had started. And so that was, a really interesting experience, and kind of going through one pain education class to another, and really figuring out that, okay, the situation with chronic pain and peers is so new that, let's really get peers trained, all peers, all mental health peers, all addiction recovery peers trained for people living with chronic pain. So the exciting part is that Oregon Health Authority has just signed a contract to do that. So there is funding for that, and that's going to be happening in the future. And that's really exciting and, brand new, but Oregon is the first state to do that. So that's really exciting. And that hopefully by next spring, we will have cohorts starting to be trained for chronic pain and to work with patients with chronic pain. So that's just so exciting. So why peers in primary care? So peers in primary care, it really is this kind of meeting people where they are. Where do chronic pain patients show up? They show up in primary care. So let's put peers into primary care, and let's get primary care really, tuned up to work with chronic pain. So that's really a lot of what I do is working in primary care and getting primary care offices, not just the providers, but the whole office trained of how do you work with people living with chronic pain. It's the billing person, it's the receptionist, it's everyone in the office, the accountant. Everyone needs to know exactly what people are going through that live with chronic pain and why. So taking the burden off the already stressed system. We know that primary care is not built for chronic illness at all, but it's putting peers into that system really can take a lot of this burden off. And it can be very cost effective. Peers are not an expensive tool that you can implement. They're very cost effective. And so insurance is not caught up with that. But the other exciting thing happening in Oregon and hoping to spread to other states is that our Oregon Health Authority and Oregon Health Plan is going to start covering peers. So that's very exciting. So we'll just keep an eye on that in the future in all states and all ways. So also being a teacher, mentor, coach, really understanding this piece of what patients and clients are going through, doing a lot of motivational interviewing, finding out, what are the needs? What does this person need? If the person needs, some support around housing, then you get them housing, you get them the resources that they need, but you're really, doing a lot of motivational interviewing to find out what their needs are and what what the provider needs and also what the patient needs also. So it's, this life experience of talking to patients about the lessons that you've learned, the falls, the gathering back up. Every peer has had kind of missteps, and it's those stories of missteps and coming back on track that really kind of can guide that client in such a meaningful way. Also being a really stable, positive influence, but having boundaries and understanding the boundaries, and having the client, the primary care provider, and the clinic to understand the boundaries also of what peers can do and what they cannot do. Tapering and withdrawal coach. So a lot of what I do is kind of speaking about tapering, what it's like, what providers should be doing with their tapering of high-dose opioids, especially with chronic pain patients, and how to even broach the subject using a lot of motivational interviewing and difficult conversation skills about tapering and the withdrawal of what it's going to be like. A lot of times patients and providers have gotten caught in the crosshairs of the pain and opioid crisis, and really this moment of nobody was willing to be uncomfortable. The patient's not willing to be uncomfortable. The provider's not willing to be uncomfortable. And that's how, the opioid crisis was really created. So the tips and tricks, I have lots of tips and tricks about tapering and withdrawals and all the things that come along with that. Also, benzodiazepine tapering is not only opioid tapering, but a lot of tips and tricks, and some good kind of difficult day scenarios and difficult day baskets, and really trying to make tapering's never going to be fun, but there can be some fun aspects of it. So bringing fun back into our lives in a very difficult situation. Caring and giving the compassion that needs to go along with tapering that gets missed a lot, that sometimes it can be a very hard line situation, and it doesn't have to be. It can be really a compassionate situation, and really learning the compassion around tapering and withdrawing and living with chronic pain in general. So, and also seeing success and moving forward, those little successes that happen during tapering, that really acknowledging those and getting those acknowledged. So an advocate, this whole thing of being an advocate and going back to, that so many times with chronic pain and chronic illness that there's not a roadmap and that there's not a navigator, but there can be someone holding your hand and advocating for you in, difficult conversations and unanswered questions that happen. Being that extra person that can listen to, an appointment and have, of feedback and have information that wasn't heard the first time, and really, advocating for the patients. Bridging the gap. So many times there's this huge gap between the patient and provider, and how communication breaks down because it is a push me, pull you situation of patients can, get ornery. Living with chronic pain makes you ornery in general. So it is, the patient, community around chronic pain can be a difficult community, but it is bridging the gap of, your provider's not trying to harm you, your provider is caring for you. So giving providers a different understanding of their patients also of, here's the story and this is what this patient is going through, and that so many times patients will tell peers really what's going on, and that, those kind of insights can be so meaningful in a situation when you're trying to, interview and motivate someone to do something different in their life. So the patient's feeling heard and understood. It's truly, that's what it comes down to. Resource purveying. So much of what I do is just going in and providing resources of, and there's not necessarily a lot of rural resources still, but there's lots of web-based resources, and there's lots of internet-based resources for chronic pain and for tapering and for withdrawal, all of the things. But there's also, it's resource purveying around housing, jobs, medical resources, mental health resources that maybe the provider didn't think of like, hey, can we try this? Or hey, what about this other resource? Maybe even in a different county that can be pulled in, that can be covered. Disability and senior resources, filling out disability paperwork can be so difficult and hard sometimes, just sitting and doing those kinds of things with patients, doing a lot of warm handoffs of, if you want to go to the chiropractor, I will go to the chiropractor with you, and make that situation a little bit easier. It's always so scary to go to a new provider in general, but if you have a person going with you to these resources, that it can make it a lot easier. And the power of, I don't know, but I'm going to find out. That maybe I don't know who to send you to, but I'm going to find out, and I'm going to get you a resource. Even if it's the wrong resource, we're going to get you somewhere. We're going to get you, to something that will lead to something else, that will lead to something else. So the resources around living with chronic pain. So there's Synergy Health Consulting, that the group that I work for. There's Oregon Pain Guidance, which is a really wonderful resource. There's Stay Safe Oregon, which is a great resource too. American Chronic Pain Association is wonderful. Then there's resources for providers. The Living Well resource is always so nice too, because it's in most communities, including rural communities, and it's just a really great resource. And if it's not low cost, if it's not free, it's very low cost. Retrain Pain is a really wonderful website for providers, that you can sit with your patients and go through a slide deck that is actually built around having difficult conversations. So you go through that slide deck with your patients, and you can actually, it prompts you to actually have the difficult conversation, which can be a really nice resource. Beth Darnell's book is always so great. It's a really nice, handy thing to have in the office, and that's Opioid-Free Pain Relief Kit. So that is the end of my presentation. I left a few minutes here for Q&As. I'm hoping that there's going to be lots of Q&As. I love questions. Anything that sparked any kind of conversation, I would love to have a conversation about.
Thank you so much for all of that, Michelle. I'm really grateful to you, especially for sharing your personal story, because I know that can be really challenging sometimes. That was a really great presentation, and the super helpful always too to get a list of resources at the end like that, because it can be sometimes so hard to find like a valid resource on that. So just a couple of reminders, and then we'll do the Q&A. We're going to have 2 surveys, one today and then one in 2 weeks, and this is your last chance to get $5 for each of those. And then we'll also be sending out certificates of attendance, and you don't have to do anything unless you are watching with the group. And if you have any questions for Michelle, please go ahead and type them into the chat box. And meanwhile, I have a couple to get us started. So Michelle, what can addiction services do to help their clients living with pain?
So addiction services is such a wonderful resource, because there's so many people going through programs at addiction resources that are living with chronic pain already. And so it's really important to have the peers, and that's really a lot of times, peers are based in addiction programs. So it's really important to have peers trained for chronic pain. But in the meantime, if we can't get them trained for chronic pain, we can get them to the Oregon Pain Guidance website. We can get them to really the opioid summits that have been happening. There was a really wonderful opioid summit happening last month in Washington. That was a great resource for addiction, that really had to do with opioids, but also had to do with pain too. And really getting those peers kind of up-trained for chronic pain, and starting kind of some groups, and having patients be able to sit together and see each other, that they're not only dealing with addiction, but they're also dealing with pain, and that support of seeing others being able to deal with pain, because we know that in addiction also, but in chronic pain especially, that people tend to isolate because they don't see other people living with pain. So it's, I'm the only one that's going through this, so I'm the only one that knows. And when you actually are in a support group and can see, that other people are living and going through the emotional states and the physical states that you're so familiar with, and being able to tell those stories amongst yourselves is so important.
Okay, well, related to that, we just got a question. Kristen says, I'm a social worker with SLE/lupus. I work in community mental health in Washington. I would love to run a peer support group for chronic pain, but I've had a hard time getting it started. Do you have any suggestions for starting a group like that?
Yeah, and I'm sorry, where did she say she was from?
Community mental health in Washington.
Yes, so Washington has some really great peer resources, and we can email offline and I can get you all those peer resources to get those peers into your realm, and that we can start and we have some resources to actually start some support groups too, of kind of some outlines and handouts of what those could look like.
Great.
You know, and you can kind of pick and choose to see what works for that group.
Great.
That's really great.
Yeah. I got a question. Will slides be accessible after today? Yes. The slides and also a recording of this will be available, and I'll be sending you a link later today. Another question, if someone was interested in becoming a peer, how would they get started in pursuing that?
So in Oregon, all peers are trained through the Oregon Health Authority. In Washington, I think that it's a private run system through a peer network. So peers can be, and there's there's a range of peers. There's a peer wellness coach, there's this peer support specialist. It's all under the category of traditional healthcare workers. And the traditional healthcare workers category that I mentioned earlier, that's what's going to start getting covered under the Medicare kind of umbrella. So that's really exciting. But to be able to be trained, there's some peer networks, and if you want to email me after, I can send you links to all of those. I should have put them in the resources. I didn't think of that. I will do that next time, though.
Sure. We have another question from someone who's interested in the resources you're mentioning for starting a chronic pain group, and they are in Montana and says they have a peer network there. So I'm wondering if maybe, Michelle, if you wanted to send me a list of resources, I can then just email it out to everybody who attended today, and then and also make it available on the website as well, if that would be helpful.
Perfect.
Oh, this is neat. She also says Medicaid now covers peer support services in Montana. That's awesome.
Oh, very good to know. Very good to know. I love that. That's great information. Thank you so much.
Yeah. All right. So another question for you. What is the biggest challenge to peers today?
There's several. My first is always coverage for insurance and coverage for payment. There's also our recommendation for, there's kind of a realm of peers getting hired, but not really knowing what their supervisor expected them to do. So many times I hear that peers were hired and that they were supposed to answer phones, or that they were supposed to, pick up the mail or do kind of more reception jobs. And that's not really what peers are meant to do. Peers use their lived experience to help others. So the challenges of, having peers know exactly what their expectations are, but having clinics and the actual authority that's hiring them know exactly what peers do and what they don't do, so that it's, clear on the onset of, here's your expectations, this is what you're good at, do what you're good at, instead of, let's put you into a job that you didn't necessarily sign up for. So that's been an interesting challenge. There's always challenging kind of positions around supervision, of course, getting the supervision, tight and right, and then also getting the right resources to the peers and letting the peers do what they do best. So, in making that kind of, a lot of times peers need to be, massaged into clinics, and that the clinic needs to be kind of up-trained too of what the actual peer does. So getting that, as a small, informal training of, here's this peer and this is what this person's going to do. So, have this person do what they're good at.
Mm-hmm. Okay, so kind of coming from the other perspective, if a chronic pain patient is having a challenge with their doctor wants to taper them off opioids and they don't feel like they're confident to do it by themselves, how would they connect with a peer advocate? Like, what would your advice be to a chronic pain patient who's struggling with that?
Oh, that's a good question too. If the peer is not built into the actual clinic itself,
yeah,
I would always, if I was a clinic and I wasn't going to hire peers, I would always have the peer network information around as a resource, that we don't necessarily have peers working with us, but here's the peer network, and that these peers are trained to help in these difficult situations.
That's great. What else could the medical system do to help with the pain crisis?
So this has been a really interesting, there's so many things on the forefront of, kind of the pain and opioid crisis. And because we've been looking at it for, 8+ years now, of that when it happened, it was, what do we do about it? And we're finally starting to get some building blocks set into place. And I really, I see that the pain and opioid crisis isn't going to go away. But there's going to be so many more things happening kind of in this frontier of, that medicine is a science, and that pain medicine is a science. And so really looking at how we deal with this cohort of what quote unquote legacy patients. Some people don't like that languaging, but that's what I use because that's what I consider myself as a legacy patient, of a person on long-term opioids, and that really, what are you going to do with this person? So it's that the science around what helps this population, but also what helps the population that's opioid naive, and to really get them the behavioral health component much earlier in the intervention, that you start off with the behavioral health intervention at the get-go. And so that's going to be this turnaround for this new population. But what do you do with the old population? We're working on it. I mean, there's a lot of science happening. There's a lot of science happening around central sensitization, fibromyalgia, and really, the concrete evidence is coming down the line, and that we need to be able to hear that and be open to it. So that's exciting.
Yeah, that's really interesting. Do we have any other questions from folks today?
And I'm always open to emails. I'm always open to any kind of conversation that needs to happen offline. I appreciate all of you being here and listening to the presentation.
Yeah, thank you, everyone. Okay, so in that case, I invite you all to join us next month for our webinar about mindful awareness and body-oriented therapy, which sounds really interesting. And thank you, everyone, for attending today. And thank you so much again, Michelle, for sharing your personal story. It's really great when people do that. It's really helpful for everyone, I think, to hear that personal story from folks.
Thank you so much.
Yeah, thank you so much, everyone.